Okay, I think I'll get things started here. Hi, everyone, and welcome to today's session of Healthy Discussions. Before we get started, I have just a few housekeeping notes. The chat box and Q&A feature are both open, so please feel free to use them. You can turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And this session is being recorded and will be posted to Quality Care NL's YouTube channel. I'd like to start with an acknowledgement that the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups, and we acknowledge with respect the diverse histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and to take a moment to reflect not only on why we are offering these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. So for those who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University aiming at improving social and health outcomes in our province. Healthy Discussions is our new webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussions also contribute to the growth of a learning health and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning health and social system as defined by Health Accord NL in its task force report. This definition might seem complicated the first time you read it, but what it really boils down to is a health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. Part of the definition states that individuals and families are active participants in all elements. By engaging in sessions like this one, by being an active participant in your own health care and wellness, by talking about and acting on issues that impact us as a society, you are contributing to a learning health and social system in our province. Today, we are delighted to have joining us Dr. Brenda Wilson, Associate Dean of the Division of Community Health and Humanities at the Faculty of Medicine in Memorial University. Joining Brendan for today's discussion is Kathleen Mather, a health policy analyst with Quality of Care NL. Kathleen has some questions to get our conversation started, but we will be taking questions from the audience. So please type your questions in the Q&A box, which is a little bit easier for us to manage. Sometimes questions can get lost in the chat as people chime in with their own thoughts. Since today's discussion is being recorded, you may wish to ask your questions anonymously, which you can do by using the Q&A instead of the chat. So without further ado, I'm going to pass it over to Kathleen to start our webinar.
Great, thanks, Robert. So we'll start off first, Brenda, with just a kind of a generic question to give us a base. So what is wellness and why is it important?
Thanks, Kathleen. So one of the things I did is I prepared for this because we all think we know what we're talking about, but I kind of thought, well, what is wellness? So I did what any good academic does, is gets onto Google to see what's out there. And, you just get hit with all of these definitions and no two are the same. A lot of them have some similar ideas. So I'll just, this is what I put up there is that this is the, where a lot of them derive from. So it's not a wellness definition, but it says health. And the important thing about this, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, that was essentially the definition that they developed. It's in the WHO Constitution, so back in 1948, and it's existed a long time, and it underpins a lot of these ideas. But when you go online and you start looking for these, you find that there's all sorts of variations on this. So there's some that look like this. But there's others that read, and I'm just going to read them out. There's no test here, so I'm not going to ask people to repeat them, but there's a different kind of tone to some of them. So one of the more complicated ones, it's an integrated method. Wellness is an integrated method of functioning oriented to maximizing the potential of which a person's capable. or it's a conscious and deliberate approach to an advanced state of physical and psychological and spiritual health. It's harmony of the body, mind, and spirit. Or it's a set of attitudes and behaviors indicating a person's perception of their abilities to have some control over their physical well-being. You start to get into the weeds with this really quickly because these are taking in different directions. That's what I saw. But I really did kind of, when I was working out, well, what are people trying to say here? And I think actually, if we think about wellness, we can think of it as a kind of a state. It's a place people find themselves in, and that's kind of the WHO definition there. It's a situation that we're in. It's a state of being, and which is hopefully a good state of being. And it can be anything from sort of more sort of health oriented, more to do with that kind of illness, healthy piece, or you can pull it out so it's a much broader idea of sort of multidimensional, and it's a quality of life, it's our place in the world and all the things. So anything between those two, but it just describes a kind of state that people are in. But there's another, so if we can move to the next slide, just to illustrate. Yeah, so this is, if you go look there are wheels like this that have 6 dimensions, 8 dimensions. This one's got 10 dimensions, but this is the idea that of moving it out from being very sort of diseasey health focused to some kind of broad idea of quality of life. This one actually came from the Department of National Defence of all places, but you can find them everywhere. But if you go to the next slide, I was also struck, and it came out with some of those quotes that I read, and we'll leave that sitting up. I'll leave that sitting so you can read it. And there's an awful lot of this about as well. So it's wellness as a practice. It's a thing that people do. So it's an active process of growth and change to find your fullest potential, really. And that it does kind of resonate with some of those other ones, but it's individualized, and it starts to suggest responsibility for doing things. It's about lifestyle changes. It's about making choices. It's about controlling. So it puts it, there's a kind of the autonomy of the individual. We are in control, and it's up to us to do this. And an awful lot of the stuff that's out there has around this, and is associated, with professional organizations, and I would say there's a certain kind of commercialization aspect that goes with this as well. So there is no one definition of wellness or well-being out there. There have been attempts to try and find the ideas of it, but I kind of do see that these are these two sort of poles of it. It's a state of being where actually you're in balance, you're confident, you're doing what you want to do, you're able to live your life the way you want to be. So there's that kind of idea. Or you're a person who's engaged and is doing all these things right in order to maximize what you are. This is a very long answer to a short question, I know, but so I will stop in a minute. But one of the issues with that kind of second way of talking is that it's a bit normative. It's about saying people should do this. We expect you to do this. And when you start to go down that language, you're getting into and if you don't do this, it's your fault. And it ignores the fact that not everybody's in the same position to do things. There's human variation, and actually we should all have choices. So the language of control and autonomy is really difficult to reconcile with the expectations that people must do things. These are not the same. I did start to explore sort of indigenous perspectives on well-being and wellness. And I did actually come across a fairly recent paper, which was really lovely. And it kind of worked through different communities and different nations across Canada, Indigenous peoples. And the things that really came out from there, not every group would have the same sort of definition, but the common themes were, it was about connectedness. So wellness is about people being connected to people. and people being connected to the land always kind of featured in everyone. And that's, I think, something we might come back to later. There were ideas of, the phrase would be living well. So well-being is about living well, or living a good life, and a conscious good life. And what does that mean? So it's about a balance between your mind, body, feeling, spirit, and it's something you aspire to, but you also work on. And it's a holistic idea, and it applies to a person, but also to a family, a community, to the world. So it's kind of scalable up, but it has all those kinds of ideas. And I think a lot of the ideas of wellness have a lot of these running through them. So I think people will come to the definition of wellness that kind of works for them, but that's where, you know, that's where a lot of the literature lies. Now, I mean, I have an awful lot more to say on this, but maybe I should stop there because there I have some more thoughts. But the starting point is this means to people what it means to people. And there's no one definition, and people are going to find their way to the one that works for them. But there are some issues with being, with the expectations we might set up on people to practice wellness. I think that's probably what I'd say.
All right, thank you. Well, I think that you know, you said it was a long answer to a short question, but I think the answer sort of demonstrates the complexity of the concept. But you mentioned something that I think ties really nicely into our next question around you know, different people's capacities and the things that might impact them. So our first Healthy Discussions webinar back in January focused on the social determinants of health. So those are the social and economic factors that influence people's health. So I'm curious what the relationship between the social determinants of health are and wellness.
Okay, so if we could flip to the next slide, because one of the things I did was to kind of go back in history and say, okay, where did all this thinking come from? And how are these things connected? And I think we go back to actually thinking about wellness. It has a lot to do with the thinking about social determinants of health, because it emerged as a sort of counter to what was a very individualistic and seen as the medical model. So the medical model, you know, and I'm a physician, so you know, I'm not sort of dissing anybody really, but I'm just saying, but typically the medical model is that sort of, it's about, you're focusing on, you know, organs and body systems and diseases, and you're kind of focusing down on that, and you're looking for things that are wrong that you can fix. And it's really ultimately quite biological. Whereas wellness is at the opposite end of the spectrum. It's multidimensional. It recognizes people as individuals and as whole people with complex lives, and salutogenic, which means salutogenesis means to create health. That's the idea of salutogenesis. So it's about promoting positive health. And so that links to the ideas of health promotion. And when you're talking about health promotion, you're very much in the territory of social determinants of health. So that's where these came from. And in fact, if we go to the next slide, I kind of went further back. And so I have my own copy of this. I am, you know, a card-carrying public health physician. And I thought, my gosh, yes, I have this. So this was 1986. It's kind of one of those big events, massive big WHO conference on health promotion. And it marks for many people the start of thinking like this. And so the Ottawa Charter for Health Promotion is a really interesting read, because it is where you start to see how we link the individual with the situation that they're in. So again, I'm just going to read this off, but this charter actually is really short, and it's written in English and in French. There's two versions of it, so it's 4 pages in there, so it's really only a couple of pages. But its starting point is it starts with that definition of health from WHO. So to reach a state of complete physical, mental, and social well-being, an individual or a group, an individual must be able to identify and realize aspirations, satisfy needs, and to change or cope with their environment. Health is therefore seen as a resource for everyday life, not the objective of living. And it goes on to say a few more things, but it says health promotion is not just the responsibility of the health sector, but goes beyond healthy lifestyles to well-being. So it starts to lay that out. And if you go to the next slide, a bit following up that, it actually says, so this is really what we're talking about with well-being. It's about people reaching their fullest potential and fulfilling one's role expectations. In other words, being the person that they want to be in their life. You know, whether that's being a parent, you know, being a churchgoer, being a worker, whatever it is, it's about people setting their own ideas. And that, I think, is where we're starting to see that, you know, health has to be driven by the person, and it's about kind of reaching somewhere, reaching what you can be. But if you go to the next slide, where people can get to, this is it, you know, so I'm going around the houses a bit, I realize that, but where people can get to is not completely under their control. That is the simple sort of piece that sits in the middle of it. How far people can go and how far they can achieve things is often determined, enhanced or limited by where they were born, what they were born into, their social position, their relationships, early childhood experiences, the isms in life, racism, sexism, more, you know, it's, do they have access to the resources to do the things? So you can want to be something, but you start off with a set of conditions, and I would say these are the social determinants of health that are going to make it possible or not. So people go on a different track almost from the day they're born. And a lot of these things connect with each other. So we talk about food insecurity, for example. So if, I think everyone would agree, you know, that healthy eating, healthy nutrition, being well fed generally plays into wellness in some ways. So how, and we talk about food insecurity. But food insecurity is fundamentally also, it may be related to education levels, etc., but it's much more fundamental, you know, it's related to how much income people have, what they have to spend. Do they have to run around to lots of different jobs just to be able to feed a family, to earn enough? And what people are capable of earning may be determined by literacy, you know, how well can they read, etc. And that's determined by a lot of other, so you see, you can't really separate these things out. So and so this kind of goes back to that kind of lifestyle idea and these choices that people make. If you push that too far, or if you push that even just a little, you start to say, well, not everybody's, no two people are alike. And where people can get to is determined really by the social determinants of health. And so, and it's unrealistic to have expectations that, well, you know, they could do it if they wanted to. Yeah, but we only have so much energy. We only have so much time, and we may be coping with lots of other things. So, and I've laid these out as capabilities principles, because this, I'll come back to that later. It's about us understanding. This is I've drawn on this from this actually came from social justice and global health and development. This is where this kind of thinking started, that communities have certain capabilities. If you want to improve equity, health equity, for example, at community level, you have to think about where you're starting from and what constraints there are. So this is where this thinking started, but it's actually some social scientists and philosophers have kind of taken it and saying, you can apply this to people. You know, it's scalable down to people as well as up to communities. And I think that's really an interesting way of looking at things. So I think, you know, we can come back, but what people do doesn't happen in a vacuum. That's a simple way of putting it about social determinants of health.
Excellent. Yeah, I mean, they really kind of tie into every component, like you said. Your comment about food insecurity just made me think about we did have a previous session specifically on food security. So if that's a topic that any of the audience members are interested in, that should be up on our YouTube channel for watching. But I might just take this moment to pop over to Robert and see if there's any audience questions that we can go to.
Sure, there actually is, Kathleen, but
Great.
before I get to those questions, I just want to briefly mention something that I should have done in the intro is that this session is part of Newfoundland Labrador's first Well-Being Week. Well-Being Week is a time to learn, engage, support, and take action around the many factors that impact our health and quality of life. It's a week to build momentum and empower people to continue making meaningful steps to better our well-being today, tomorrow, and beyond. And if you want any more information, you can visit their website at www.wellbeingnl.ca, and you can see a full list of scheduled events for throughout the week. Now, without further ado, I'm going to get to a question from Tony. Do you feel that currently the word wellness is attached more often to physical and mental, but we don't use it quite the same with other areas of aspects of our lives?
Um, I think probably I agree with you. It depends where you look. I was doing a sort of deep dive into Google, and you could find, and I went onto the sort of academic databases to search for, published literature on this. And honestly, it was coming up all over the place in relation to everything, any kind of clinical discipline, any area of healthcare, whatever. But I think particularly in the kind of the mainstream sort of, non-academic side, if you just go onto a search engine, I think those are two distinct threads. Definitely, mental health, mental wellness came up a huge amount. But there was also a very separate piece that I was seeing that where this was very linked to physical activity and physical well-being. I mean, really, basically, it was about exercise and lifestyle. It's very much that end of it. So I think those are two sort of things. So yeah, I think, Tony, I would agree with you.
And I'll have one more question before we continue. Can you comment on mindfulness as a form of self-care?
Oh, well, that's a really interesting one, and I haven't used that phrase, and I haven't gone there. I have a complicated relationship with the idea of mindfulness. I think being mindful and being reflective and learning to be in the moment and learning to see the world around you, and particularly in at times or moments of kind of stress, or when things are kind of crowding, that kind of context, I think that's it's part of us learning to understand ourselves and to regulate ourselves. So, I might kind of put it differently, emotional self-regulation, learning to handle ourselves and to not just be reactive to our circumstances. Now, I'm going a bit away from the idea of mindfulness, but you're getting what I think. I think that's all a good thing. And it's in my job, which kind of, there's often a lot of craziness goes on. There's a lot of things coming at me at once. And a lot of people have jobs everybody has jobs like that. Stuff's just happening and coming at you. And you have to kind of see yourself, position yourself in it, and be able to respond and sometimes step out of yourselves and take that breath and see yourself and see the situation. So that's how I think about mindfulness. And I think that's really useful. I think as a whole industry has grown up around mindfulness. And industries growing up around anything to do with healthcare always bother me. I would like to think that mindfulness practices and intentional mindfulness practices being built into, education, etc., that they are beneficial, but the evidence base is pretty weak. We don't really have, last time I looked anyway, there wasn't a lot of strong, good evidence that this was as helpful as people think. So I feel that people want this to be helpful. Whether they are, I think, is less clear. So I'm just waving my hand because my light's going to go off in my office if it doesn't. It thinks I've gone to sleep. So so I do have that problem, and if we start to promote something, particularly in workplaces, say, if we start to promote saying, okay, we're going to have a mindfulness practice, you really want to certainly you don't want people to get very cynical about this, that it's a nice cheap thing to do. But anything that we do, if it's not really effective, then it's a waste of people's time at the very least. So I would feel better if we had more evidence about how mindfulness, the benefits it really brings. So I'm not saying it's not effective, it's just it's not as well developed. And I feel uncomfortable when people jump onto this as a simple thing to do, assuming it's beneficial. Because sometimes the real problems are other things that we should be solving, which is too much work for people, expectations of working at home. The work-life balance piece is usually more about too much work, to be honest, or the workplace environment. So let's make sure that that's the right thing for the right place, and it's not being used as a kind of panacea when there are other issues that a work or a school or some other context, should be getting fixed. Yeah, I feel like I'm being a bit too honest there, but that's how I feel about it. Good question.
That's all I got for now, Kathleen. So you can continue on with your conversation.
Okay, perfect. Thanks, Robert. So I feel like this kind of touches into a little bit that mental health question. So wondering how can our health and social care systems impact our overall wellness?
A lot. The short answer is they can a lot because, okay, let's accept that wellness goes beyond strictly healthcare and the health system, and this idea of health as being around not being ill, that piece. So I'm not going for that big huge quality of life thing necessarily, but I'm just going for that more traditional idea of health. Then obviously the health system is really important to that, and the way that people are treated. Now, I mean, it's the nature of to run a health service. You've got to make choices, and you've got to make it systematic. This is the way we do this thing. These are the processes we have. This is how you get admitted. This is how you see your doctor. You have to run it. It's an organization, or these are complex organizations. And you can't personalize those parts of the system. You can't sort of say, we're going to run an admission system that's like this for this person and that for that person. So you have to do it that way. But at the same time, what that does is it has the danger of making people feel anonymous and treated like just another number. And it sort of sits at that, in opposition to this idea that what we're trying to do is help people, optimize their potential and listen to their, these capabilities things, listen to what is it that they want to do, what do they want to get from healthcare. So there's an inherent tension about efficient running of a health system with treating people as individuals, if I can put it that way. I mean, if I kind of unpack that a bit more, what would an ideal health system be like if it was actually attending to wellness? That might be another way to think about that. So, start with the culture. The culture is the kind of the collective behaviors and attitudes that we just take on that are just there. And when you have stigma, when you have a tendency to blame people for things, when we have racism, when we have judgmentalism, when we have sizeism, whatever, we're inherently stigmatizing and making judgments, and we're working against wellness. And any one person working in healthcare, you couldn't go to any one person, they wouldn't kind of say, yeah, I like to blame people. We don't see ourselves like that, but we we practice those unconscious habits, and collectively we can make people feel like they don't matter so much. And when you start to do that, they're not going to speak up. They're not going to say what it is that what they want, what they need. They're not going to share and disclose. And it kind of cuts across sort of working with them in a sort of health partnership way. I mean, I'm going to, like a really simple thing I noticed, and I thought, this is great. Notice how in many healthcare institutions, like 20 years ago, maybe even 10 years ago, if you go to a waiting room, the chairs are all the same size. Now we have much larger chairs. We accept that people are different sizes. Let's not make people feel embarrassed because they can't, they're too big to fit into a chair. That's a really simple thing. There's lots of little things like that. So it's about kind of thinking, what are the ways we can make things more comfortable and we can show that we accept everybody. I think it's a huge piece about absolutely at the center of healthcare is that relationship between each health professional and their patient or their client, the person they're caring for and they're working with. So much hinges on what goes on there. We've moved away from, I hope we've moved away from, well, I'd like to think we've moved away from, paternalism. Yeah, physicians generally do know more than patients about the things that physicians know about. Patients know much more than physicians about their own lives. And these need to meet in the middle. And there's been a lot of move away from, the paternalism to a sort of more of a partnership idea. In fact, I think I don't know if I have a slide for that. Do you have a slide for the health system? Just thinking.
Oh, looks like we're getting.
There we go. There we go. There we go. That's it. Because so the whole idea there's I was for quite a few years on the Canadian Task Force for Preventive Healthcare, and that develops guidelines primarily for primary care, but can be used elsewhere, about evidence-based preventive care practices. And right at the heart of all of the recommendations we made was thinking about a healthcare professional and a patient and how they work together. So it wasn't about you must do this. It was about saying you need to help people to here's what the evidence says, and here's the kind of the scope. Here's the harms and the benefits, and here's the scope for this. And you need, the idea is you should do everything in the shared decision-making context. And that's an easy thing to say, and it's a hard thing to do, because it means you've got to have the time. You've got to see the person in front of you for who they are. You've got to make a space for them to feel confident, and to take the power that they can take or they want to take, and to help direct things the way they want to. And to not practice checklist medicine. Okay, this person's here and, okay, there's 6 different things I need to do with them today. Actually, turning that around and saying, okay, tell me what's going on. What's the most important thing we should be trying to work on? And kind of, it's a relationship, not just an encounter. And seeing the person, not seeing the condition. So all of that is really, I think, what sits at the heart of it. And there's this idea of, I put minimally disruptive medicine. That it's I don't know how familiar people are with that, but it's the idea that, people's lives are an awful lot more than coming for their hospital appointment or their doctor's appointment or whatever, if they can get one in the first place. And that's a different discussion. But we need to kind of keep ourselves in check and understand we're a small part of people's lives. And we need to understand their lives and try to disrupt them to the least extent possible as far as they want. So let's not make everything we do such a big deal that it dominates everything and takes away from people just getting on with the stuff that they want to do. Let's understand, especially for chronic disease management, someone's living with a chronic disease, if health is a resource for living, let's not make the kind of the medical side of it and what we're doing in healthcare. Let's not kind of make that a big thing that gets in the way of people getting on with their living. That would be the idea of wellness. Now, there's the last point on that slide I put up, best use of resources. So I'm not an economist, but I understand economics is the science of making choices, especially, health economics. If you spend resources on one thing, they're not available for something else. So we all have a vested interest in using our resources really well. And resources is money, resources are people, resources are time. And that's why using evidence to inform what we're doing is really important. Because if we're doing things where there's no evidence, we're effectively wasting our resources. So there's a kind of real alignment of evidence-based approaches within the context of people being able to make decisions of their own lives and actually making best use of resources so that, if we have more money, we can pay more people or we can give people more time. It's kind of time and people are what we need in healthcare. We don't have enough healthcare professionals, and those that we do have don't have enough time to practice the kind of care that they've been trained for. So all of these things, again, another complicated answer to a simple question. There's a lot that the health system could do. It all starts with person-centeredness and respecting them in the middle and understanding the effects they have on people's lives, but also that they really have to not be the biggest thing that a person has to deal with. Because if people are putting their energy into dealing with the health system, they're not living the best quality life they could have. She said.
Well, I think perhaps anybody sitting in on this will think twice about using wellness flippantly moving forward, because it's such a complex term and encompasses so much. Now you've kind of touched on my next question, so feel free to let me know you've said everything you want to say about this, but kind of when it comes to general health and wellness, like you've mentioned, there can be a lot of onus placed on the individual to make healthy choices. So eating well, exercising, making lifestyle changes, getting those screenings done. So are there ways that providers can best support individual patients in being and staying well beyond what you've already kind of talked about?
I mean, I think we actually have covered these quite a lot. Am I right, Melissa? There's only one slide left after this.
Yes.
Is he okay? Yeah. So let me take you back. Remember, I had a slide about. In fact, I'm sorry to do this, but let's do this. If you can go back up to the capabilities principles, thank you very much. You're with me. Let's unpack a bit more this idea then of sort of meeting people where they are. So I'm much. It's not. This is not about the health system writ large. It's actually about those relationships that we have within the health system, particularly professionals with patients and clients. So the capabilities approach focuses on what are people capable of doing and what's important to them. And the sort of questions that you ask in that are saying, what does this person in front of me value about being able to be? Who do they want to be? So it could be, do they value being respected, being a good parent, being free from pain? What is their state of being? What are the things that are really important to them? And what are the things that they really want to be able to do? Is it about kind of being able to enjoy a hobby, being able to get back to work, being able to volunteer, whatever? That's where it all starts, the capabilities approach. And if you're able to kind of tune into that, even accepting there's going to be restrictions on what they can do, perhaps because of their income, whatever, but asking those kind of questions gets you to, or starts you kind of starting to understand who is this person. And these are not things that you're going to get by looking at them, by knowing what their gender is, what their income is, knowing whether they're racialized or not. It doesn't matter. Those kind of things, those indicators, they don't matter, because these are the internal things to the person, and you have to work with them to know them. And then that is where you start, because that's going to help you in that kind of sort of person-centered approach to say, okay, if the thing that's most important to this person is they want to be a good parent and be able to play with their kids, then it frames all of the other kind of things that we do in healthcare for them, and the potential direction for different kinds of preventive activities. Instead of focusing on, we have to prevent disease X, or we have to make sure that you get your HbA1c if you're diabetic. You know, if you're living with diabetes and the focus is always on, you know, that blood test result, maybe in fact you'll start to say, okay, what are the ways that we can make sure that you can be that kind of parent that you want to be? And now it's a bit radical, I kind of get it, but that's so much that we deal with in healthcare, and so much that people have to deal with, is chronic disease. No, we're in this province. Think about our indicators for chronic disease, and risk factors for chronic disease. These all start to kind of make sense, you know, if you line these up. So, you know, and my comments, you know, if we're going to offer things to people, if we're going to go to people and say, we think it would be good if you get screened for this or screened for that, just remember what we're doing is going to people and we're offering the possibility of finding out that they might have yet another diagnosis. We better know that there's a good evidence base for doing that, and understand where that's going to take us, you know, the different pathways that it could take that person. And understand if they say, you know, I don't think I want this. And that is the exercise of autonomy, and it's giving people the confidence to say that. So people have the right to say no to things. I live in you know, an imaginary utopia, but but allowing people to say no and not judging them for it, and saying that's okay. That's a really thing. It's a really hard thing to say, and it's a thing I've said. You know, look, I'm a physician, and I have said no, I don't want that screening. And there's times when I've had to really push hard. I'm one of the best equipped people to say no. And it's kind of like, no, I've got to kind of put my foot down, and I've got to explain myself, and I shouldn't have to do this. And I have the tools to be able to do that. So if I find that hard, good grief, you know, we don't make it easy for people. So
Well,
that's yeah. I don't know where that takes us, but
I mean, it does lead me to, I think I can kind of tie it into my next question a little bit. So you talked a little bit about how really what seems like is lacking in the system is the time and the money. So certainly the utopian version of healthcare that you described would take a lot more time than the typical 10, 15-minute appointment a physician has with a patient. So perhaps I'm wondering how decision makers might best support population health from a policy perspective. And I don't know if maybe that's a you know, a policy type response that could change, but I'm sure you have other thoughts as well.
Yeah, you know, that's a really simple answer. It goes back to the social determinants of health. You have to invest. The problem is it's a long-term thing. Social determinants of health, you're not going to see that big tanker, that big ship turn around really quickly, because you're in the scale of multiple years to see the benefits. But the evidence is generally pretty good that the benefits will come. So, but I think, so if we're talking about policy, it's about effectively having the courage to do something now. It's like planting a tree now that you may be long gone before it reaches maturity, but you're not going to get the tree unless you plant it now. It's a bit like that. So just committing and knowing that it is going to pay back to the population, to the community, over time. So those social determinants of health, social economic determinants of health, it is what's going on. It's going on here, and it was built into the Health Accord, and it's not rocket science. It's what makes people, fundamentally what makes people healthy is economic stability. Having enough income to you know, to live on, to feed themselves, to feed their families, to have stable housing. Now that's at the very basic level. Uh, it's about having an environment that doesn't pollute, you know, pollute the air. It's about valuing and remembering how incredibly important is the very early childhood years are in setting a trajectory for a person's life, what they're going to achieve. And so investing in children and in education of children and care of children, because it pays back intergenerationally. You have to be able to stand back and see that kind of big picture and over a big time scale. But it takes a certain amount of political commitment and courage to do that, I think, when we have, and I'm not going to go into politics, but we have election cycles that don't lend to that. But we know what to do. We know what to do with that. And over time, it pays back. But it requires that kind of ongoing upfront investment. You know, and it takes a while before you see it. I mean, I don't know that there's anything else I can say about it because it's so fundamental. I suppose I would say that if you're going to invest in healthcare, invest in primary care. This is a no-brainer, and this is I go back to the early years when I was kind of learning public health last century. How do you know strengthening health systems, and we're talking about global development and social justice, you start with strengthening primary care because everything starts to follow from that. It's your best investment on the healthcare side, and it pays back much more. I know that we love high-tech medicine, but you're going to get much more from employing, you know, finding more family doctors and primary care practitioners and other health professions as well, than, you know, buying another MRI scanner or whatever. You know, you got to get those people. That's what rights the system. I don't know if that answered your question.
I mean, I think it certainly does, and it's a you know a fairly straightforward answer, I think, from a policy perspective. So that's great. Robert, I'm noticing the time. I have one more question, kind of in this suite of questions, but I'm wondering if you've got audience questions that maybe would make more sense to try to get to here before we run out of time.
Yes, absolutely. I have one here from Andy. And I remember this because it actually popped up in a previous healthy discussions. The question goes, are you familiar with the Blue Zones initiative and what is your perspective? In particular, their approach to a city/place committing to changing the environment to make wellness easier/more natural.
You know, I've come across the phrase, Andy, but I'm having trouble sort of connecting to where I read it, but I think I have the idea. In fact, it really fits with where I was going to go with the end of this, I think, Kathleen. I mean, I don't know, Robert, is it possible to ask Andy just to say a bit more about this?
Yeah, sure. Andy, if you want to put in the chat room a bit more information about Blue Zones. But in the meantime, I can perhaps go on to another question. Do you see a role for community health centers based on models in Nova Scotia, Ontario, and British Columbia, playing a role in redefining wellness, shifting care from hospital settings, you know, illness and disease-centered focus to truly grassroots community settings? Now, I know you touched on this on your last question, but if you wanted to elaborate on that.
Yeah, I mean, the short answer is yes. Um, so forgive me for this. So you can tell from my accent, I wasn't born and raised in Canada, and it's always just struck me as just how long it takes places to learn from each other. So in the 1970s, 1980s, 1970s, you know, the National Health Service in the UK. So no health service is perfect. I get this. But the NHS I was brought up with and trained in and, you know, learned with and made use of, community health centres were there, you know. And so what I'm talking about is you would have you'd have a building, you'd have a place, and it would have family physicians. It would have what in this country are called public health nurses, who would public health nurses and midwives, and you'd have nurses attached to the practice, so kind of like nurse practitioners as well. So the different kinds of nursing differentiation there. And also you could have coming in and out other kinds of professionals, for example, dietetics, etc., etc. And the kind of really smart thing that happened was that the government of the time, and it was set in and this carried on, was they made it easy for family docs to set these up because they basically paid for the buildings. So they didn't have to incur the mortgage costs and all the rest of it. And they would actually be paying the salaries of a lot of these other professionals. So it was a collaborative care model. And it was the bedrock, and it is the bedrock. And it's where primary care developed. So you would go see your family doctor, and a lot of them would be working out of health centres. That's what they were called. And that's the model that we're seeing here. And it's just taken, it's decades late, but I find it really hard to talk about this because it was just like, it was the default and it worked really well. And they'd be in communities and they would be the hub. They'd be the center, but they'd be big enough that, people would cover for each other. But very locally centered as well. So they would cover geographic locations and populations, as opposed to, I live here and I'm going to drive 20 miles to see my family doc. No, my family doc's going to be, 5 to 10 miles away at most, kind of thing. So it's, I actually do think that that's the way we should be doing here. And I see that we're slowly starting to get here in different provinces here.
So Andy followed up that basically blue zones are in alignment with addressing the social determinants by getting the community to help itself. But I did just do a quick Google search, and basically blue zone projects takes an environmental approach to health, improving street and park designs, public policy, and social involvement so that it's easier for people to make healthy choices in the places that they live, work, learn, and play.
Yeah. So Andy, I did read about these. I just didn't click on the name because the idea is just, I think this is where we're starting to see an alignment that, and it is in many ways that idea is the embodiment of this kind of wellness as being people in their environment. You can't separate people from their environment. We don't have an awful lot of time left, but I don't know. Can I just keep going, Catherine?
I think if you don't have anything, we're happy to stay on a little bit, appreciating that people might need to drop off. But I think sometimes we've gone a little over if the conversation is still going well.
Yeah. So blue zones, I think is not far off from this. This is the last slide I'm putting up, but things get different names, so I don't really care what they get called. So I don't know whether eco-wellness is exactly the same as blue zones, but it's coming from a very similar way of thinking, which is realizing that, and probably if I stretch it, I could link this to the idea of One Health, which is, not separating ourselves from animals, for example, understanding that animal health is our health. So, we're connected, everything, we are a huge ecosystem. So we were going to have a conversation about, how climate change impacts people's wellness. I think if anybody who hasn't been around, who doesn't see that, hasn't been around this summer, look at what's gone on across the country of very direct effects of climate change and how it's displaced people and actually directly affected health with smoke, forest fires, smoke, etc. I don't think we need to kind of go into that here, but we can see that in front of us. I hear the stuff around, was it climate anxiety or eco-anxiety, some kind of free floating. So I foresee a new DSM diagnostic category being developed, but it makes us all feel really unsettled, and it clearly plays into, without minimizing it, anxiety and fears that we might have about where things are going. And I will say, I kind of think, okay, yeah, is this it? Is this what it is now? We also know that climate change is changing the epidemiology of diseases. It's changing the epidemiology of, where communicable diseases that are spread, or go through different kinds of animals or insects, etc. As their sort of habitats change, they shift around. So we should be expecting to see, mosquito-borne diseases, more and more frequently. In fact, we do see them in Canada and in areas of Canada. So our climate's changing, our landscape is changing, habitats are changing. So there's all these are direct, fairly direct. But there's also kind of the indirect effects that, as farming changes, as people are displaced because they can't live on the land that they were anymore, you get these big shifts of, you get environmental refugees, if I can put them that way. And that starts, and we see what's going on with refugees and mass movements of people around the world now on a scale we've never seen before. That some of that can be traced back to sort of climate change, and so you can't separate it from politics. So this is very indirect, but that affects all of us. So many ways. Turning it round, there's this observation that some of the things that are bad for the climate and bad for the environment are bad for us too. And so if you start to address one, you're actually addressing more things. And that's where I'm kind of linking it to the blue zones idea. Eating meat is associated, meat's not the healthiest thing to eat, or at least certainly some meat isn't. And so even just from the point of view of energy density, actually, how many calories do you take in when you eat meat versus how many calories do you take in when you eat plants? Think about obesity, think about cardiovascular disease, things that are related, circulatory diseases, strokes, etc. They're all kind of tied in to some extent with what we're eating. So shifting people away from so much meat and towards plants is likely to help chronic disease prevalence. It's going to make people healthier, all other things being equal. That's going to reduce greenhouse gas emissions. So food production in itself generates anything between 26 and 34% of greenhouse gases at the last data I looked at. Meat generates more than double the amount of greenhouse gases than the equivalent in plants. So, that would be good for the environment as well. It's sort of one way of looking at it. So the things that would make us healthier are better for the climate, better for the environment. And a really thoughtful paper I came across started to pull this in and said, and the 4 areas I've listed are the ones where there's most alignment between the needs of the environment and the needs of people. It's to do with transportation, walkable cities, getting people out of cars, good for the environment, good for people. So that starts to play into that blue zone idea. Food choices, just talked about that. Indoor air quality. We've seen a lot about air quality with the fires. There's an awful lot more to that, but starting to understand that air is the new water. We need to learn to clean our air. And it makes us focus on what are we doing to put things into the air, okay? And green space immersion seems like just a fancy term for saying people getting out and enjoying the outdoors, into forests, into parks, into green space. To do that, you have to have forest parks and green space, and people have to have time to get into them. But when you're investing in those, it's actually good for people's well-being as well. So there's areas where it looks like you have this alignment, and so we can think about climate change and about the ecosystem and the environment more generally, not as only as something that causes people to be ill or undermines wellness, but as an area where in fact we're going to get like bang for our buck by thinking about these. So the blue zones idea particularly is kind of, it's almost like a win-win. It's like, why is that not a good thing? Apart from the fact that some people, it may challenge how we think things should be. But really, honestly, I think we're kind of trying to kill ourselves as a species at times. Okay, that's a bit dark. I didn't mean to go there. Maybe we should actually start to find the positive way out. You need to stop me talking.
Well, Robert, I think that that's probably a good time for us to hop over to you for our wrap up then.
Absolutely. Yeah, so that concludes the time we have for today's session. I want to thank Brenda and Kathleen for leading us through a great discussion on this important topic. A big thank you to everyone who joined us online to listen and participate in our discussion. And just a reminder that a recording of this session will be on our YouTube channel in the coming days. And you can check out the recordings of all previous sessions. They will be there. We'll be joined by Planned Parenthood, the NL Sexual Health Center, for our next session in October. So keep an eye out on our website for when registration opens for that. Lastly, you'll see a very short post-event survey on your screen after we end the webinar. We'd appreciate you providing any feedback or ideas for any future healthy discussions. And lastly, it was a pleasure for Quality of Care NL to be a part of the first Wellbeing Week. And again, I encourage everyone to visit the website for further information and events, and I believe that was put into the chat room. So thanks again, everyone, and have a great day.
Thank you.